kind of thing. It's very interesting. The last two speakers, Molly introduced by saying, look, our health research board is interested in this area around implementation, knowledge mobilisation, but they're obsessed by impact, and that is the way over. And also the same listening from the last speaker, who talked very, very much about that the public health focus was also wanting to look at what are the outcomes and the impacts. So it's a quite challenging field to work in, and I suppose one of the things is not to worry too much about that impact stuff, because as we've seen from Maureen, it doesn't always go hand in hand with that, and when you're trying to get up and do the things, perhaps we should put those things to one side, and maybe we can deal with the impacts in various ways. And that's what I want to talk about in a way today, because I want to show how there is a disjuncture, a temporal disjuncture, if you like, even when you have all the money in the world to do it, between the outcomes and what's expected of you by policymakers or by practitioners or by the culture of evidence mobilisation. I think it's really important to keep that in there. So the one thing about knowledge mobilisation translation, immediately people's eyes glaze over. I was talking to a friend on the phone last night, and she said, "Where are you?" I said, "Oh, well, I'm in Galway doing that." She said, "Oh God." She said, "I'm glad you're there and not here," because it conjures up something not very very clear and not very accessible. And so I think there is a terminology. And if you actually Google knowledge mobilisation or translation, you get a whole range of things that come up. Collaboration, research, decision making, solution to the underuse of research in practice, in policy. It starts talking about how knowledge should be co-produced and joint development of questions and answers. So it's not a very nice, tidy definition, is it? So it's already starting with a legacy of a language and a narrative that may not be that engaging. That's what I like to say. And so I want to really talk a little bit about two things today. One of them is about the collaborations and leadership for applied healthcare research. It's funded by the National Institute of Health Research, and the specifics of one case, which is about implementation of support for long-term condition management and a journey that goes with that as a result of that. So I belong to this thing called NHIR Clark Wessex, and they like you to really brand everything. If you don't get branded for anything, that's one of the things is I'll get a nasty email if I go back and they find, it's a Galway, where was it? So here it is. And I do understand why they do that, because actually the NHIR puts £1 billion worth of money into applied health research in England every year. So that's 1% of the NHS budget. So I do understand why they do that, and I'm very appreciative of it. So I'm not underestimating that, and that's why they do want to have. I think they are concerned about value for money and the fact they're pumping all this money in, and what is the profile and that kind of thing. So it's important. So in terms of the vision, our Clark was on improving the health of the people of Wessex and quality and cost effectiveness of healthcare. Actually, Wessex is really a Thomas Hardy construct. It doesn't really exist in reality, but it actually covers Hampshire and Dorset and a bit of Wiltshire and a bit of nice seaside really, and we call it Wessex because it's supposed to cover more area. There are 13 of these in the UK. There should be 15, but two weren't successful on quality last time. So it should be national. And really ours was focused on the step changes in integration of pathways of care for people with long-term conditions, and particularly about reducing hospital admissions and readmissions in terms of more appropriate healthcare utilisation, which is something the UK is very concerned with. So there's not so much what our Clark was concerned with, but the Clarks in general have been concerned with the second translational gap, which was set out by Cooksey, in trying to mend the disconnect between the development and implementation of the interventions and how those are implemented in practice. So So this is what the aims of all the clerks were. It's to develop and conduct applied health research relevant across the NHS and to translate those research findings into improved outcomes for patients. It's also very much about creating a distributed model for the conduct of research that links those who are doing the research with all those who use it in practice across the health community. And that is the big ask, because of course a lot of researchers are in universities doing research. They have a whole lot of set of things, goals, impact factors, things that they're concerned with in their socialisation, and those who actually want to improve practice on the ground. And so a lot of the clerks really are about building networks and connections with one another, and that actually doesn't naturally, in the first instance, provide impact. But I can tell you from our clerk, 4.5 years in, is that actually it has done that. I don't think the medical faculty really had very much to do with the health sciences or the psychology faculty previously, and now there is collaboration across things like ageing research or long-term condition research. There is that buy-in, and it was not necessarily a very easy journey. And there is also then a connection with the health community, and I think I'm really lucky having moved from Manchester to the South Coast, because everybody at the health service seems to be extremely collaborative. I don't know why that is. I always remain amazed about how enthusiastic they are about doing research, how much they want to be engaged, how much they want to support things. So that bit of it has actually been really easy in terms of doing that. But bringing the two together is complex because of the institutional barriers. So that's what the aims of the clerks are. Whether they're the good value for the £150 million that have been invested in the last 5 years, I don't know, because I think it's very fair to say is that everybody feels, here people starting on a journey, not very well funded and everything, and what do you do with 150 million quid? I think there is an issue about value for money. So although I think you might be very envious of the money that's gone in there, I don't think money is absolutely everything. This is just where it fits in the infrastructure. So I said the NHIR does a lot of research. They do a lot of biomedical and experimental research, and then they deliberately put this along here around adoption. So that's just to give you an idea about where it fits in. What was our approach to implementation? Well, in the bid we put these things there. You can have direct knowledge transfer on building, on exploiting things that we know work. Is there a clinical guideline that isn't actually implemented in practice? Is there already evidence for that, but how do you roll it out? The exchange through social interaction is really important, this face-to-face working with people in the health system, and then encouraging environmental and organisational readiness to do research. And that is quite difficult and requires specific projects to do that. And then facilitating knowledge through translating heuristic tools. I put these out there because, it's all ideal types. You put that in the bid. I don't know what to extent we've actually done that. It looked quite good in the bid, but I think it has been very difficult in practice. What I think has been very important is we've had clinical academics leading research and implementation themes. So people, nurses, health psychologists, medics, who are also clinical academics, they've been leading the themes, and I think that's been really useful in actually getting the translation accepted and adopted, because there's the issue about trust that you talked about. There's a trust. You have access to patients, and also to the tacit knowledge of what practice is about. So I think that's probably accounts for some of our success, I think. And so we've had all these themes: public health and primary care. They're all about long-term condition management at a large extent. Complexity and end-of-life care, self-management, fundamental care and hospital ageing, dementia, and integrated respiratory care. And we've also had a lot of patient and public involvement, and I know that there's lots of developments in Ireland around that. I've been working with Anne McFarlane in Limerick. around that, so I know that you're very well advanced for that. And we've had what's a methodological hub. We don't like themselves being called the Met Hub because obviously at the time of Breaking Bad, the public health people said you cannot call this the Met Hub. So now they're more respectably called the sort of Data Science Hub. But they don't do what they did in Breaking Bad, but what they do is actually wonderful operational modelling of key problems that are of direct relevance to the NHS, so responsive mode. So what on earth do you do about the A&E problem in terms of people absolutely queuing up? Anyway, in the UK it's been absolutely sort of horrendous in terms of pictures of ambulances queuing up and what to do with patient flows. And they are able to respond to that because they can actually run a model about the likely outcomes, doing sort of mathematical modelling, and give people at least an answer. I mean, usually the answer is, I wouldn't do that if I were you. But that's been really important in saying, look, there are academics here, and they do operational things, and they can answer your question, not in 10 years' time, they can answer it actually in a few months' time. So having that kind of operational modelling, along with the health economics, has been really, really vital to us. So I want to really talk here about the role, the natural history of the development and rollout of the social network intervention designed to support long-term condition management. The reason I've chosen that is that so I've been lucky enough to be a member of teams that have received lots of money from the NHIR over time, 10 to 15 year period, or the Department of Health before that. And so that consistency of funding allows you to learn from what you do and do something different and go on and do that. And I think that is the big advantage of having consistent funding rather than just, this is the project. They say, what's the outcomes? Oh, it didn't work very well, did it? You know, okay, put in another project about something else and show impact. So I do think there is something to be said for having long-term funding. And like in Ireland and the rest of the EU, self-management has been, for long-term conditions, has been a big issue, really, I suppose, for managing demand or managing what's seen as an ageing population. And we all have triangles, and I think these look like fallopian tubes, but that's the one from the US, the chronic care model, looking at that. So a big focus on policy, and when started off in this area, you got a Labour government that just went crazy about producing loads and loads of policy about self-management for long-term conditions. The good thing was they were very focused on long-term condition management. I mean, but then there was this tsunami of policy documents about addressing that. Actually, I don't think we live in such times anymore. People are sort of like absolutely the opposite, stuck in a policy vacuum, really, around some of these things. But there was a huge investment in thought and in terms of doing research around self-care support. But really, despite all of those things, they were really focused on one thing, which was the expert patient programme, which is actually the chronic disease self-management programme, which was developed at Stanford University. And so this sort of like implementation of expert patient programme. But nationally, every PCT, that's Primary Care Trust, was charged with implementing it in that area. And that was the old NHS, where somebody just said, you will do this. And they all did. So that was, I sort of like look romantically back on those days when policy had that thing. But the thing about that, this is the whole thing about evidence-based. So actually, the Department of Health got hold of the LORIG model, and they said, this has been the success in Kaiser Permanente. It's obviously going to be a success in the NHS, so let's roll it out. And then they sort of got a little bit of cold feet, because when we said, well, actually, there are other self-management things, and what is the evidence for the LORIG model and that kind of thing? And there are randomised control trials, but there's also a lot of questions, really, about some of the outcome members. And when I went on a trip to Kaiser Permanente to see the wonderful rollout of the expert patient programme, there they said, well, what do you mean? Oh, of course we don't use that. So I'm being recorded, I know that. And they got in a bit of a fluster about it, because although Stanford had promoted that, the Kaiser Permanente were not using it in regular practice, and so that was quite interesting because a lot of their physicians didn't want to use it; it was too cumbersome or whatever. So this promoted policy had been imported into the UK on the premises that it worked, but actually when you looked at it, it wasn't necessarily in practice in health services in the US at that point. Anyway, so they then this is how policy works. They said, oh right, okay, thanks for that. Well, would you mind doing the evaluation of the expert patient programme? Because I work for the National Primary Care Research and Development Centre in Manchester, and so we did a large RCT, and we found some interesting things, that actually people's self-efficacy did go up as a result of doing the 6-week programme. But in terms of a process, it was a poor fit with NHS administrative practices, and a lot of burden for little public health gain, and the reach was limited. In fact, we interviewed GPs and they said, no, we don't refer people to that. We don't really know what it is. And we do chronic illness management in primary care, so I don't want to refer my patients here. And they put it in the bin with the pieces of paper. So about the referrals. So the reach was limited. The people who got the most out of it really were the trainers, who really liked doing it. And that's quite good because it gives employment to people who do it. They loved it. So there was some, overall one size didn't fit all, the generic thing. And so there begins the snakes and ladders, the relationship between policymakers, because I think we thought we were being terribly liberal. Well, we would go along to talk to the policy people, and we would take notice in the process evaluation of what they said was working with the trainers and that. And actually it's really, really difficult working with policymakers at that level, because they're interested in other things. It was actually quite, I felt that the actual being accessible, they kind of didn't really appreciate that. They just blamed us for everything that was going on. And then I call it the bury it moment. It was in Richmond House, like having watched The West Wing. It was like we produced this report that says something like, well, GPs tend to put the bits of paper in the bin and there's no reach. And then they said, you've got to bury this report. It was like, no, I'm sorry, we're academics, we don't do that. The bury it moment, let's call it the bury it moment. But actually, on reflection, the whole idea was that the trainers were trying to put an innovation into practice. And then you've got a whole lot of researchers coming along and saying, this doesn't work, that doesn't work, or whatever. So how are they going to promote an innovation that they want to get adopted? And that was their aim with researchers coming along and really showing some of the limitations. So I do understand in retrospect their attitude. But I think the positive is that we came away from that able to learn from that experience and think about a redesign and try a different innovation with buy-in from those on the ground, namely in primary care. So I'm lucky National Primary Care R&D Centre got a lot of money, and we came up with what we call this WISE approach, which basically was based on this model. I'm not going to go through all of it, but where actually it was based in primary care, where the decision support was very much part of training professionals to incorporate that into their everyday work, and so we used clinicians and GPs to do the training, and we thought we got it sussed, changing bits of the programme so that it was relevant information, a negotiated plan, and taking into concern the NHS system. So we were pretty pleased with ourselves about doing that, and then it what transpires is there was training of whole practice teams in the kind of needs that patients had about self-management, shared decision making, those kinds of things. So it was all worked out really. I haven't time to go into the details, but there was a lot of effort put into the whole idea about a menu of options, not just one thing, links to the voluntary sector and those kinds of things. But despite a very long and arduous randomised control trial of a large number of practices, there was no effect. In fact, shared decision making got worse at 6 months. So it was actually we felt devastated at one level. Anyway, did get the RCP Research Paper of the Year award. It was extremely popular with GPs because it said, actually, God, you found one thing that we can't do. It's this. Thank goodness they're not going to ask us to do it anymore, which wasn't anything. So what you're saying is the intervention was the sort of trial was successful because it was implemented so well, but the outcome was bad. But I think this thing about trials is that it really does mask what works and what doesn't. So it was not a total failure in from our point of view, because we did a process evaluation as well, and we engaged a high proportion of practices with the programme. The whole of Salford, the whole of the Northwest, people were actually falling over themselves to be involved in the programme. So I think absolute engagement in self-management from that was brilliant. The staff all went to the training, including role play and that kind of thing, and we ensured the training was relevant and accessible by adapting it. But it's this thing about encouraging implementation of training and routine practice is partially achieved, and part of that was because of the quality and outcomes framework tariff, which didn't have self-management on it. So people were very interested in getting biomedical outcomes and achieving those kinds of goals, but this wasn't on it. So actually, of course, it got marginalised because didn't become part of routine work, and this shared decision-making self-management wasn't achieved at all, and that's because, of course, it's difficult to do shared decision-making and self-management in 10 minutes when you're doing all the rest of it in a consultation. And it also wasn't absolutely sure it wasn't achieved, because the people, the practice nurses, for example, who were trained in psychological short interventions, actually were able to do it, and they did do it. But I do think it is also, again, pointing to the things that are missing in terms of trying to implement something. And improving outcomes, it didn't achieve that, obviously. At the same time, there's this thing going on at the policy level. While we're talking about the details about who can do shared decision-making, who can't, whether it fits into the QOF, what actually it is like on the ground. And they're still talking, it starts to be policy rhetoric about, active, expert, resourceful, prudent patients. It starts to be a huge disjuncture between that kind of policy rhetoric and what you're actually confronted with in practice. And so in terms of trying to do things with policymakers, some of the things don't easily translate. This is not the way in which patients think about themselves. This sort of over-activated stuff. It feels like, you just press a button and, you're going to be activating self-management. Patients are also extraordinarily resourceful. So you're getting a whole critique there about the ideological overload of what comes in with policy, which makes it very difficult then to do that sort of knowledge translation, because you've got a disjuncture. It's just something to think about. So I just want to say, then after our experience in primary care, we were lucky even to get, we were really lucky because we just kept on getting funding for new ideas, which I think is quite good. We were able to build on it. And so we put more of a focus of taking self-management support outside of primary care to focus on patient contexts and networks. And because we realised that social networks are actually centrally involved in the mobilisation and deployment of resources in the management of chronic condition. One of the things the patients said, well, we don't go to the GP to do self-management. They don't do that. They do your bloods. So when you talked about looking at the support that people got, it was actually much more out in the community, out in their personal networks. So that's why we focused on that. And we're not the only ones, obviously, because this whole idea about the collective behavioural change that comes from networks is obviously it was promoted by Nicholas Christakis and John Fowler from Harvard. So this whole idea about moving away from individual behavioural change to collective behaviour change was in the air. And so this is sort of where we sort of also incorporated that. And we also sort of started to think about the theory behind self-management support. We didn't like all that activated, empowered people stuff. What did we like? And one of the things we returned to was more sort of sociological theory and looking at to achieve outcomes. Do you have to really go with what people value and what they have reason to value? So one of the things that came back to us is that people with long-term conditions, what they valued most and had lost most was connections with other people. So having a long-term condition meant people were less mobile, that people around them had died and they'd lost connectedness, and that they valued doing everyday activities. Yes, they did want more information sometimes about managing better themselves, but most of all, they didn't. They just wanted to carry on as long as they could, doing things that they enjoyed or valued. So we took that away, looking at sort of issues about preferences, not looking at issues about whether people were doing the right thing about goal setting or self-efficacy, even those things can be very useful. And we started to look at the issues about relationships and interdependency as a way of sort of a resource for mobilising kinds of support. So the systems of support become much wider. It involves people's personal communities, their friends, their relatives around them, voluntary community groups. Health professionals do feature there, but also non-health professionals with health-relevant functions, including weak ties, were also really important. And so we did some longitudinal surveys and a randomised control trial, looking at the role of networks in long-term condition management, and we did actually surprisingly find some positive outcomes, so we were pleased about that. But we found that those people who had contact with a larger set of and a bigger variety of people and groups actually had better personal self-management and physical and mental well-being. So there was a connection between being connected to groups and activities that actually improved people's self-efficacy, that enabled them to self-manage. So it's about looking further back, I think, in terms of looking at behavioural change. And then we also looked at the sort of support work undertaken by people's personal networks and found that they actually expanded in accordance with health needs, helping to cope with people with their conditions. So rather than an inverse care law, when people had a relapse or couldn't manage, then members of the network tended to step in and support them. So it was quite a sort of resilient network, if you like. And that actually that those who had more contact with network support, it does substitute for formal care, which is the holy grail of policymakers who are very concerned about health service utilisation costs. But it doesn't come just from the individual, it comes from that individual who connected into a set of resources and diverse activities. So then, this is the intervention that we've been busy implementing now as a result of that. Really, those three bits of work, learning from the two bits of the work and learning from the network stuff. So we have this thing called Genie, which is an online social network intervention that is actually facilitated by somebody, in which we actually, in terms of behavioural change, we don't start looking inwards. We say to somebody, who in your network at the moment supports you, and what do they do, and how do they help you? And could you actually indicate for us on the network where you would locate them in terms of importance, the value to yourself, and actually what is the objective sort of illness work that they do for you. And the idea of that is that, first of all, it's a visual tool. It also gets people to sort of move away from looking at themselves and to sort of actually at the same time reflect on what their needs are. And then the second thing we do then is look at what their preferences are for a range of different activities. So that can be things like volunteering, it can be to actually get health information and knowledge, it can be walking, exercise, hobbies, anything. And so we get people to identify the preferences, and then this is a picture of the Isle of Wight here, through a resource which lists a lot of things, we come up with possibilities for people to link in to activities or relationships that they might go to. So that's the basis of Genie, and so we have done evaluation of that and found that actually in most cases that people's networks do expand as a result of having done this intervention. They do make contacts, often things like walking groups, and people move around in and out the network. So sometimes it's good to kick your partner out to the outside one, because all their resources have been used up, if you like, and you need to make more contacts, or different types of contacts for support. So that's how Genie works. We sort of know it does work also we've done some trial evidence and things like that. And we're actually now, in terms of dissemination, there's quite a lot of people using Genie. I'm still waiting to hear from the NHS to see whether they're going to include it on their framework. I hope they will do. But of course, we used it in the Isle of Wight, we've used it in housing associations, we've used it across Europe, in Dorset, in Seoul, in Southampton, in Canada, in Hamilton, with people looking at public health intervention. And the commissioning group in Southampton have now bought it. They've commissioned it because this involves quite a lot of a computer and programs and keeping it updated and that kind of thing. So we do have a license. It's not designed to make a profit, just to keep it going. So they bought it, and it's being promoted by NHS England. So I think after 15 years we might have got somewhere in terms of implementation. But I think the lessons are, it's got a long way to go in terms of implementation. But so what are the lessons? Well, there's a lot of lessons. That social structural support for researchers, together with knowledge mobilisation information, is crucial. So thank you to the NHIR. You know, I love them, and everybody else loves them. But without that, it wouldn't have been possible, because we kept on applying for funding and getting different types of funding. Even though in one project it could have been seen as a failure, that they've been doing that. I think one of the things is always try to place one project, one effort in broader context of policy and practice over time. Because of course it's dispiriting to get back a large randomised controlled trial that everybody's been working on really hard and say it doesn't work. So you could go away and just cry, or you could say, you know, what do we actually learn from that? And I think looking at things like the process evaluation to show where it did actually work in the RCT and using different methods is really important. So I don't think failure might not be failure, but a part of a journey. So I think looking for improvements in translation at the margins is actually really quite important. There will always be a tension and a gap between ideal type policy rhetoric and practice on the ground. And I think now I wouldn't have got so upset about it, about, you know, what I thought sometimes was ridiculous policy statements and what everything. It's just the way it is, really, in terms of the work, you know, what policymakers have to do to promote a policy. So it's about identifying that rhetoric, learning from it, and look at what it implies for your own project, really, I think. Then there's a lot of theory happening about knowledge mobilisation that's going on. I like theory, but I think however interesting these different theories are, they can't really be more than a set of sensitising concepts, because the actual idea about implementation and knowledge mobilisation is very, very messy. And the messiness and chaos of what happens in practice and the serendipity of what is taken up in practice can't really be accounted for by these theories, which sometimes people can take very literally and try to sort of link them into that. So that would be my caveat, coming from somebody who does like theory. Relational work needs to be the centre stage of knowledge mobilisation, and the project that Una and I worked on, we certainly found that however good your innovation is, if you haven't got the relational work happening with the professionals and the patients, it's not likely to be implemented. So relational work, relationships, and how that happens really needs to be up front. And the knowledge you identify as crucial might require a total change of mindset to get your research into practice. So I think you have to be prepared. If you're doing research, knowledge mobilisation, you might find what you set out with isn't what is actually required or what comes back. So I think in terms of the stuff about the social network interventions, one of the things that came clear is that pets, in terms of self-care support, are more important in terms of mediating relationships and providing emotional support than any health professional. Now, it's really difficult to come up with a thing like that, because, you know, are they really going to give everybody a pet or support pets to get rid of health professionals? But it keeps on coming up that is. So that's one of the things that, you know, now gets centre stage. We have the network, and we have a special place for pets. So pets to patients, not professionals, is an example of that. So I think I've run out of time. If you want to know more about Genie, then we've got our own webpage, and so please do contact us about that. So thank you very much for listening.